And I promise I did not set this agenda. So I was the PI on FRESCO-2 as well. So very gratifying to hear real-world experience. And I think, to cover other options that are available as well, Sunlight trial showed that TAS-102 plus Bev is active in the third-line setting, and the approval for fruquintinib came in for both third-line and beyond. So I think an ongoing debate, an unanswered question is, how do you sequence these therapies? So curious to get your thoughts and how you guys approach this.
You're in my head, because that was exactly what I was going to ask next. So yeah, that would be great. Tell us more about how you sequence, because that is a challenge especially when teaching fellows who are going out into practice. And I tell them, I say, usually it's whichever attending you practice under, that's what you end up doing for the rest of your career until new data comes out. So let's hear what you all do, because I bet we all do something a little bit different.
Yes, yeah, I agree. It's a very, very difficult. We don't have data really to guide us on this. I think one thing that's very helpful with FRESCO-2 is we do have evidence for fruquintinib both before and after TAS-102, regorafenib, or both. So we can feel good about using them in later lines. We can also feel good about using it before those agents as well. To me, I think a lot of it comes down to toxicity. I think a lot of patients, after 2 or 3 years of cytotoxic chemotherapy, their bone marrows are very beat up. So I often will use fruquintinib, I would say third line, largely because it just gives them their bone marrow a break. It's active. We've mentioned, the quality of life is usually quite good. So I do tend to favor that, I would say. Lonsurf can be tough. The myelosuppression, the neutropenia with it is very challenging at times. And so I think giving some space between FOLFOX, FOLFIRI, and Lonsurf can be helpful. And also, I would say importantly too, most patients are probably going to see 4 lines of therapy. So to me, it's not so much a question of, are you going to give both of these? It's a question of the order in which you're going to give them.
Right. And just to add to that, a logistical issue is, these patients have been carrying a pump for over a year, and they are tired of it. So when they hear that they don't have to carry the pump and they can take a pill at home, they are ecstatic about it. So that's another practical point. And as Suneel said, that we want our patients to go through all lines of therapy, because when we smartly sequence therapies in a way that they can receive all effective lines of therapies, that's when we actually maximize their survival. So that's another important thing to remember. Just we want to give them all, just sequence it in a way that they can tolerate it.
So let's talk briefly about Codebreak 300 and how that changed our treatment paradigm and our thinking about treatment as well. Suneel, you want to start?
Yes, yeah. So this was, kind of opened the era for KRAS targeting in colorectal cancer. I mean, it feels exciting to even be able to talk about that. So this was sotorasib combined with panitumumab. So that's an important part of the story, that in colorectal cancer in particular, you really need that EGFR inhibition in addition to KRAS inhibition, unlike what we see in non-small cell lung cancer or other tumor types. And that's due to EGFR being a downstream escape mechanism for KRAS. So this is a chemo-free regimen, targeted therapy, and we have now phase 3 data showing a response rate around 30% and very impressive median overall survival. So it's a rare target still, 2 to 3% of colorectal cancer, but still I think really ushers in the KRAS era in CRC.
Right. And as Arvind was mentioning, now there's a pan-RAS molecules are coming out. So I think we will see this paradigm is expanding down the line.